Hello, everyone. I hope you're all doing well. My name is Rashida, and I'm one of the chairpersons at SUPTA this year. Welcome to the second session of our annual teaching series. This week, we are focusing on peri-operative care, and we're very happy to have all of you here with us today. Today, I am joined by Joe, who will guide you through post-operative care. Joe is a third-year student from the University of Southampton. To make the session as engaging as possible, we'll be releasing polls throughout the session. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll address them at the end of the session. We'll also share a feedback form at the end. If you complete this, you will receive a certificate of attendance and exclusive discount codes for Pass the MRCS and Teach Me Surgery. This session is being recorded, and the recording and slides will be shared on our Meta page as well as our website a couple hours after the session. So be sure to keep an eye out for that. As some of you may know, we have launched our very own learning portal, which is hosted on our website. Through this learning portal, you get access to practice questions, session recordings, as well as revision material. As a bonus, all members will get a discount code to get 10% off the Geeky Medics Anatomy flashcards, Surgery flashcards, and Knowledge Bundle. Membership is completely free, so be sure to head on to our website after the session to explore this. We also have an exciting opportunity for all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we will provide. The more sessions you attend live, the higher your chances of winning. So be sure to stay until the end of today's session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, which is the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Joe.
Hi, good evening, everyone. My name is Joe. I'm a third-year medical student from the University of Southampton. It's great to have you all here. I believe it's a long day, regardless whether you're coming back from placements or wherever you are in the world. Hope that you are doing well. So today, I'm here to share with you about peri-operative and post-operative care, as this is a continuation from what Mark, our previous speaker, delivered in the first session, which was about pre-operative care. So these two sessions are mainly covering the scope of what anesthetist surrounds surgery. So obviously the role of anesthetist cannot be undermined. This is a team effort, it's MDT. Without anesthetist, even though some might see that their role might not see their role as evident as the surgeons, but everyone's role in the MDT team is equally as important, because there's work to be done in before, during, and after surgery. So these are some of our partners for SUPTA, including RCSE, MDU, and Geeky Medics, among many. So what we'll be going through today includes a few learning outcomes, which I'll share with you all. If in any moment that you feel there's any questions or you'd like to share anything, just feel free to pop the questions in the chat, and we have a few people to discuss, and we can discuss it at the end as well. So there are a few things that we'll be going through today. First of all, we'll be just slightly going through peri-operative drug management, which Mark covered yesterday, which includes medications such as steroids and diabetes, and also some drugs. What are some drugs that you need to stop, change, or start? And then we also talk about group and safe, and as well as cross-matching, which are essential components to be checked and screened before carrying out surgery. Then we also slightly go through some peri-operative procedures and protocols in emergency cases, some measures to enhance patient recovery. As we understand, as someone goes through surgery, the body ultimately takes a toll and there's stress on it. Hence, what are the necessary steps needed to lead to optimum recovery after surgery? And we'll go through the sequence of events during surgical anesthesia, like what happens, what's the when you see anesthetists, injecting always in syringe, checking the monitors, what are they actually doing, and we go into a bit of pharmacology in terms of exploring the types of anesthesia and their mechanism of actions, and yeah. So those were like before and during surgery, and we could talk about what happens after surgery, such as post-operative nausea and vomiting, uh, usage of catheters, nutritional support, which is an important component as well, and many, many more. And lastly, we come down to the post-surgical review, which is uh, what you do during ward rounds. Yeah. Okay. So we can start now. So yeah, so what does the perioperative medical management mean? So the perioperative period actually extends from perioperative day through operation and into post-operative recovery. That means before, during, and after. So this whole process right here, before, during, and after, is important as this is to try to help prevent or at least minimize the complications that a patient can face, to reduce post-operative pain, and most importantly, to accelerate recovery to get them home. So there are a few components of perioperative medical management. So this was covered in the first session as well. For example, first of all, understanding what before surgery happens, having clocking the patient, understanding what surgery they're undergoing, its indication for it, and what are some things to take caution about. So there needs to be accurate documentation of preoperative medication, and if we were to stop some medications, what are the rationale behind it? Are there some drugs that we should give beforehand, for example, analgesia or VT prophylaxis, and many, many more. So when we come to the topic of diabetes, it can be a tricky one, as we understand that, first of all, that patients with diabetes are actually at a higher risk for perioperative complications. So actually in a study carried out in the US, among 1,042 patients who underwent total hip replacement, the rate of post-operative infection in people who had diabetes were actually higher than people without diabetes. And this could be uh, due to several reasons. For example, people with diabetes are more prone to longer wound healing times, and they have more risk, more further complications, both macro and microvascular complications as well as neuropathy complications, if not achieving glycemic control. Hence, adequate glycemic control is very essential prior to elective surgery. So the goal of perioperative control is to avoid ketosis and to maintain glucose levels within the optimum range. So generally, we will try to aim for blood glucose levels to be around 6 to 10 millimoles per liter. But 4 to 12 is an acceptable range for wider scope. So there are various units used, such as mg per deciliter as well, but we will be looking at it from millimoles per liter in this case. So that's for blood glucose levels. In terms of HbA1c, which is a more accurate marker, where HbA1c is measures the component in your blood every 3 months. So HbA1c monitoring, this is according to the NICE guidelines. So if a person's HbA1c is more than 69 millimoles per mole, you have to refer to MDT team who manage the diabetes optimization. And surgery may or may not proceed. And if it does proceed, there has to be some caution with it. But if there's HbA1c is more than 85 millimoles per mole, that could mean the person's glycemic control is probably not that well. And same, you still have to refer to diabetes team to discuss, and surgery could still be proceeded if there's a necessary need. And of course, all this is pending upon discussion of the MDT teams. So there are many factors of how we titrate and depend blood glucose concentrations include, for example, required duration of fasting, timing of surgery, whether someone is having it in morning or afternoon, what are the usual treatments someone is on? Is it insulin, especially if they're type 1, or diabetic or anti-diabetic drugs, or what's their usual diet, other comorbidities, and many more. According to NICE guidelines, all patients should have emergency treatment for hypoglycemia written on their drug chart upon admission. So here is a table summarizing some of the common diabetic drugs uh, and what we should do before, during, and after. So, for example, if we are having like oral hypoglycemics, for example, biguanides for metformin or sulfonylureas, um, like gliclazide. So the day before surgery, we would discontinue, and on the day of surgery, we omit the dose. And during surgery, we would give insulin in either subcutaneous or IV formulation. And after procedure, insulin is given until patient is no longer uh, nail by mouth. Whereas for insulin, is the usual dose before surgery, but on the day of surgery is omitted, similar to oral hypoglycemics. Okay, so that is for diabetics. Now we come to steroids. So we did mention about as someone undergoes surgery, the normal physiology of the body is to release cortisol because body is under sympathetic, is under a lot of stress. So sympathetic nerve system is activated, hence a lot of cortisol and all is released to equip our body to deal with all these external stimulus, injuries to the body, and many more. So when it comes to someone who is on patients who are on long-term steroid therapy, whether to provide preoperative supplementation doses is quite a tricky topic. And several studies shown that a stress dose is only needed when the hypothalamic pituitary adrenal axis is suppressed. So the image on the right here shows the three centers of the stress response system. You can imagine it as like the hypothalamus being the factory, of being a factory manager, instructing the workers, which is the pituitary gland, to uh, to ask the retail stores, which is the adrenal glands, to produce the final product. So it's like a three-step pathways. Yeah. So when using perioperative steroid supplementation, doses should parallel the physiologic response of normal adrenal gland to surgical stress. Okay, so we've covered diabetic and steroids. So here are just a rough image of several drugs that should be stopped before surgery, which include ACE inhibitors, ARBs, um, combined COCPs, as well as antidepressants. Okay, so now we come to something that we should start prior to surgery, which is VTE prophylaxis. So whenever a patient comes into hospital first, the first thing they'll be doing is risk assessment for VTE. So it's actually a preoperative evaluation to determine a patient's risk of developing a blood clot. So blood clot has potential to lead to pulmonary embolism and many more further complications. So this is done upon admission to hospital, and after 24 hours is done again, and whenever the clinical situation changes, it's deemed to be if it's deemed suitable, then it'll be carried out. So there's actually three parts to this. The first part, as you can see on the image on the right, this is a form by the Department of Health. The first one evaluates a person's mobility, whether persons will be lying on the bed for a long time, or is it like a day procedure? He goes in and come out, then probably VT is not necessary. And the second part is thrombosis risk, and the third part is bleeding risk. So based on this assessment, then you will determine whether VT prophylaxis is necessary. So VT prophylaxis, to reduce the risk of VT in surgical patients, regional anesthesia should be used over general anesthesia if possible. And there are two types of VTE prophylaxis: mechanical and pharmacological. So um, mechanical prophylaxis, there are two types. One is anti-embolism stockings and intermittent pneumatic compressions. So you usually see that some patients they would have these stockings ready, and like the nurses would prep them as we go into surgery. So this should be offered to patients with major trauma or those undergoing like abdominal, thoracic, or elective spinal surgery. So this should be continued until the patient is sufficiently mobile or discharged from the hospital. So that is for mechanical prophylaxis. What if in terms of pharmacological? So this should be considered in patients uh, undergoing general or orthopedic surgeries when risk of VTE outweighs the risk of bleeding, because it's always trying to balance the benefit and the risk of when you're trying to give VTE prophylaxis. So there are a few types which Mark did mention as well yesterday, such as low molecular weight heparin, fondaparinux, sodium, and many, many more. Of course, this prescription of VTE prophylaxis also depends on several factors such as person's renal function and many, many more. Okay, now we come to group and safe and cross-matching guidelines. So group and safe is like the pink blood tubes which you guys have every time you take. So the main difference between group and safe and cross-matching is that group and safe, we are trying to determine a patient's blood type, so whether it's A, B, or O, and their rhesus factor. However, for cross-matching, it's actually part of the final step of pre-transfusion compatibility testing. So in group and safe, we actually are screening for atypical antibodies. We are not mixing any blood. But in cross-matching, we are actually mixing the patient blood with the donor blood, as this is the final step before we give the blood to the person who needs it. So we're trying to see if there's immune reaction in cross-matching. So here comes to our first question, which if you kindly release the question. So we have our first question here, if everyone can see it. Is like to ask, which of the following is the primary purpose of performing a cross-match before a blood transfusion? What do you guys think is the most, what's the reason we perform a cross-match?
So 90% of the people have said D.
D. Oh, sorry, Richard. Is it B or D?
D, so the last option.
Oh, okay. So it's actually B, is to ensure compatibility between the donors and recipients' blood. Because earlier I mentioned cross-matching, we are mixing the donors and the patient's blood because we're trying to see if there's any immune reaction, as this is the final step of before transfusing the blood to the patient who needs it. Yeah. It's not really to identify any existing infections in the donor's blood, and A, to determine the donor's blood type. That is for group and safe, where we usually take 2 pink bottles. Okay. Okay. So now we come to moving on into preoperative procedures and protocols. So you can actually see in this picture here. This picture actually illustrates the sort of the pathway that someone's or we say how someone goes through what their body goes through when they're having elective and emergency surgery. So normally when we have surgery, we tend to drop a bit, but we will tend to recover as the body is always is trying to uh, get back into having negative or positive feedback to reach back into homeostasis, which is a balance level. But in actually, you see in emergency surgery, what a person's body actually goes through is much more of a harder road or curves, as you can see as from the baseline. They actually get an acute illness, and then there is some re-equilibration before they go back to surgery. Hence, it's even more crucial for someone who is undergoing emergency surgery to have adequate care and support. So, Now we come to talk about ERAS protocol, which is known as Enhanced Recovery After Surgery. So ERAS, which is a program initiated by Professor Henrik Kelly in the 1990s, is actually an important focus of preoperative management after many types of surgery such as colorectal, vascular, and many, many more. So these programs were set in place in terms to try to modify the physiological and psychological response to major surgery. And it's actually good outcomes such as reduction in complications, reduced hospital stay, improved pulmonary function, earlier return of bowel function, and people can get back to their normal lives much easier. So there are a few key principles of this protocol, which includes preoperative counseling, which includes giving the patients information about surgery, what they go through, and how what's the necessary steps they should take after the surgery. There's also preoperative nutrition. So before every patient undergo surgery, there is a screening tool which we can use. It's called Malnutrition Universal Screening Tool, MUS. So it actually assesses a patient's status as someone who is malnutrition is even more susceptible to post-operative complications. However, if through clinical examination, if someone who is really cacaxic, looking very thin, there's very severe muscle wasting, that could be a sign of malnutrition as well. However, that's why dietitians play a key role in this. And of course, also avoidance of preoperative fasting and carbohydrate loading up to 2 hours preoperatively, and also the standardized anesthetic and analgesic regimens and early mobilization to try to get patients to uh, moving and try to get back to their normal selves as soon as possible. Okay, so thus far we have covered all the drugs to stop, to change, to start, and also some of the protocols. Now we have come to anesthesia. So what exactly happens during anesthesia? So when a person is put under general anesthesia, or what you say, they have gone to sleep, there's three components to this. The person is deemed to be unconscious. Person is put on anesthesia to relieve to reduce pain, and also muscle relaxation. So there are a few stages of anesthesia, which is induction, maintenance, and emergence, which is to wake the person up. Okay, so some common techniques seen in anesthesia includes the laryngeal mask airway with spontaneous ventilation. So this is generally used for elective or emergency surgeries in patients who have been fasted and there's no risk of aspiration of gastric contents. So some common risk factors for aspiration, if it does happen, include like this person has reflux or intra-abdominal pathology which raises intra-abdominal pressure. So this can be used in patients in supine or lateral positions. So because the position of insertion of the eye gel is starting from the epiglottis until the point behind the laryngopharynx. And here we can see two images, which first one with the endotracheal tube, which is to provide a definitive airway and to where anesthesists can also control a patient's ventilation. So this allows them to have a good control over the situation. And also there's another one called rapid sequence induction, which is to protect the airway if there's any risk of aspiration of gastric contents. So the anatomy shows the location of applying pressure over the cricoid cartilage. Okay, so going through the sequence of events, now we come to stages of anesthesia. So how does someone go from alert to go to sleep? So the first stage, this is based on Goodell's classification, is based stage 1 is anesthesia or disorientation. So this is the induction state. So patients are sedated, they slowly get relaxed, their breathing gets a bit slower and more regular. Stage 2 is deemed to be the excitement or the delirium stage. So it's a bit more uncontrolled movements. Patients could have a bit delirium, um, hypertension, tachycardia, but airway reflexes remain intact during this phase, and they're often hypersensitive to stimulation. So if you want to do any maneuvers or intubation, this is still not the stage yet. Whereas stage 3, surgical anesthesia. So this is when eye movements are ceased and there's respiratory depression. So airway manipulation is safe at this level. So stage 3 is where usually we want to reach. Stage 4 is the stage where we want to try to avoid, as this occurs when too much anesthetic agents is given relatively to amount of surgical stimulation. So this is table summarizing clinical assessment of stages of anesthesia. So stage 1, stage 2, and in stage 3, you can see there's multiple planes as well. Okay, so um, why do anesthesists give general anesthesia? So because surgery is painful. Yeah, you are making an incision. Yeah, is you're trying to save a patient. So you're trying. So the goal of general anesthesia is to try to make a patient as comfortable as possible, to render them unconscious and such that they're unable to feel the painful stimuli while controlling autonomic reflexes. So there are a few classes of anesthetic agents: IV, inhalation. You have neuromuscular blocking drugs, and many more. So this is quite a complicated slide illustrating the mechanism of action of general anesthesia. Practically, what is important is that it something to do with the GABA uh, receptors in our neurons in our brain, and also and how the codium, like the chloride channels, are involved in this. So if you can look here, GABA A receptors are involved in this, and GABA is actually inhibitory neurotransmitter. So GABA is released at inhibitory synapses and they bind to postsynaptic GABA A receptors. So, oh, sorry. Okay, GABA A receptors, yeah, and these allow chloride to enter the postsynaptic neuron. So it actually causes hypopolarization of the postsynaptic neuron, and thus this inhibits the pain. Okay, so there are a few types of IV anesthesia. Among them includes propofol. So it's usually used for induction and maintenance of anesthesia. Um, and the advantage of propofol is that it can awake someone with minimal residual sedation, even with prolonged infusion, and it has some antiemetic properties as well. So it's actually propofol. It binds to GABA receptor A, and this causes influx of chloride ion, leading to hyperpolarization and inhibition of action potential propagation in the postsynaptic membrane. Yeah. And now we come to inhalation anesthesia. So some in inhalation anesthesia include like nitric oxide for gases. So the key measure for inhalation anesthesia is minimal alveolar concentration. So this is a concentration that will prevent movement in 50% of patients in response to painful stimuli, such as a surgical incision. So here is a table illustrating the differences between IV and inhalation. So the main difference, IV is usually used most of the time, and it provides a quick, smooth induction of anesthesia, which bypasses the few stages of anesthesia I mentioned earlier, like stage 1, stage 2, which is excitement and delirium, and finally stage 3, surgical anesthesia. Whereas for inhalation anesthesia, it can be utilized in patients with difficult IV access. For example, if they have a lot of bruises, AV fistula, many wounds, so it's difficult to access that, and or sometimes it could be a person who really afraid of needles, or for example, pediatric patients. So those who can tolerate them, so those who need the mask, and can tolerate them better, then inhalation anesthesia are an option. But there's also talk like the effects of like nitrous oxide on the environment, and and of course some research are now ongoing on how we can tackle this issue. So IV anesthesia, besides propofol, there are a few other types such as thiopental, desflurane, and sevoflurane. Okay, so now we've come to the second question, which is what is the which of the following is the most common side effect associated with the use of inhalational anesthesia? Is it hypertension? Is it nausea, vomiting, bradycardia, or hypothermia? What do you guys think?
Okay, Joe, while people are answering that, do you mind pressing hide on the little pop-up that's there at the bottom of
Oh,
your screen?
okay, sorry.
Thank you.
Apologies. Okay,
That's all right. We have 54% saying bradycardia and 45% saying nausea and vomiting.
okay. So it's still quite close. Okay. Um. Okay. So the answer is actually nausea and vomiting. So bradycardia is quite a common side effect, but we usually observe that nausea vomiting happens after administration of volatile agents such as isoflurane, sevoflurane, desflurane. So this is something called post-operative nausea and vomiting, which we will come about later as well. So there are many reasons behind this, such as the type of anesthesia used, what the procedure is about, and of course, it differs from patient to patient. Um, yeah. Whereas malignant hyperthemia is quite a um is quite a rare side effect of anesthesia drugs, but it's quite a serious one. And but there's a reversal agent for it. Okay, so now that we talk about anesthesia, we come to analgesia, which is what is call it to painkillers in simple terms. So, according to WHO, they have released an analgesia ladder. So, for someone who is experiencing pain, so pain is a really subjective thing, and you and me, everyone, we experience pain in our life, and some of us can tolerate it well, some less likely. So, um, and pain has exerted a huge burden on the healthcare system as well. So, the type of analgesia we give has to be quite systematic as well. Hence, WHO has released this sort of like ladder in terms of the steps, in terms of linking to a person's severity of uh, condition in terms of like matching the right analgesia. So if someone is having like very mild pain, then probably a non-opioid plus or minus with an adjuvant therapy, for example, like paracetamol. However, if someone is having like very severe pain, then interventional treatments, should be given, like opioid in IV formulation, probably, like oxycodone or many, many more. So just now we mentioned about one's like side effect of anesthesia, which is post-operative nausea and vomiting. So this affects approximately like 20 to 30% of patients within the first 24 to 48 hours post surgery. So it can be quite distressing for patients, as they can't control it, but they just feel like, so just don't feel well, and you keep vomiting out, that's not a good feeling. So this actually increase recovery time in hospital stay. It can also lead to metabolic alkalosis and also aspiration pneumonia and many, many more. Okay, so here are some risk factors for post-operative nausea and vomiting, split it into patient, surgical, and anesthetics factor. So for some reason, females are more prone to post-operative nausea and vomiting, as well as the elderly. Um, Likewise, for people who have previous episodes of nausea and vomiting and motion sickness. And for someone who undergoes like intra-abdominal laparoscopic surgery, or if there's prolonged operative times, this can also contribute to post-operative nausea and vomiting. Some anesthetics factors include, like for example, opioid analgesia, inhalation agents, and many, many more. Okay, so if such this is such a tricky thing, how do we tackle this issue? Definitely, it's not a good feeling, right? Nausea, like feeling nauseous and you want to vomit. So there are some drugs that we can give, but first we have to understand the physiology behind nausea and vomiting. Hence, we have the enteric nervous system as well as the receptor trigger zone in our brain region near the brainstem cerebellum. So whenever there's increased like intra-abdominal pressure, or there's electrolyte imbalances, or anything like the triggers, like the risk factors mentioned earlier, this can actually trigger the chemoreceptor trigger zone, which leads to sending impulses to the vomiting center from at the medulla, which initiates the vomiting reflex. So there are a few pathways here which some drugs can target, like for example 5-HT3 antagonist, using ondansetron, or metoclopramide, So the key takeaway from this slide is that um, there's no one to use all drugs. So there's like multiple drugs should be used to tackle this issue, as there are multiple pathways which can lead to initiation of a vomiting reflex. Okay, so now we'll talk about urinary catheter. So urinary catheters are also known as Foley catheters. So you can see this frequently in patients who are undergoing surgical procedures. And if you can see in this image here, um, the anatomy of the female and the male system. So the catheter is inserted through the urethra into the bladder. So what's the reason behind this? Why do we have to put catheters? So it actually serves to prevent bladder distension or incontinence when the patient is anesthetized, as well as to facilitate measurement of urine output during and after surgery. Because we can expect someone to be less mobile compared to before they were in the surgery. So um, we would really want to avoid the scenario of them, having a full bladder and then having a full outburst, something like that. Yeah. So these are slides showing the possible infectious and non-infectious urinary catheter complications, such as bacteriuria, increased incidence of UTI, can lead to hematuria if someone tries to pull it out, and clots, many, many more, if it's not kept clean. So hygiene is quite important. So this is where patient education is quite important as well. So, but ultimately, this is not something to be kept in place forever, unless the person is having issues with his or her bladder. Hence, we will try to always after a period of time to go with trial without catheter, or we call it talk. So talk is when the catheter which has been previously inserted is removed for a trial period to see whether patients are able to pass their urine as normally as they were before. So they will be asked to drink plenty of fluids, and then if the urine pass is sufficient, then everything's all right. Okay, so I know we've covered quite a lot right now. So, but now it's moving to the after stages of surgery. So now we've come to talk about post-operative nutrition. So we know that surgical procedures can induce a hypermetabolic response on the body, where body increasing protein and energy requirements. Hence, nutrition is an important component here, where the dietitian's role cannot be overstated, because post-operative malnutrition can actually impair immune function, increase mortality, increase length of stay, compromise wound healing, and increase complication rates. So there are a few types of post-operative nutrition, depending on a patient's condition. For example, whether a patient is able to um, to have something able to take medications through his or her mouth, whether able to eat normally, or if someone is like after a major uh, like gastric bypass, any abdominal surgery, you might have, or any, like after whipples, and they might have after an anastomosis, might have to be on NG tube or NJ tube for feeding. Yeah. So here's a like showing table showing the hierarchy of feeding. So for example, if the esophagus is blocked or dysfunction, then the patient could be indicated for PEG, percutaneous and endoscopic and gastrostomy. And also, if the stomach is inaccessible or there's outflow obstruction, then jejunostomy is done to allow jejunal feeding. Okay, so then now we come to the calculation of individuals' nutrition needs. Ultimately, there are many calculation methods out there, um, but there's one here which is the Eat Well's guide, which actually divides the food and drinks that we consume usually into five main groups. So on average, women should have around like 2,000 calories a day, while men should have around 2,005 calories a day. But this does not apply to children because they have different nutrition needs. But obviously, this is very vague, and much of it depends on the patient's condition, and also a discussion between the NDT team and also the role of dietitians here, as we need to if anything, understand that to refer to them so that they can come up with a suitable dietetic plan to improve the nutritional status of the patients. Of course, considering both the clinical picture and as well as their individual preferences. Okay, so now we've come to quite important common post-operative complications. So complications do happen at times, and they are talked about prior to surgery. So the list of it is uh, non-exhaustive. There are many post-operative complications such as anemia, wound dehiscence, where if the suture is not tight enough and falls out of place, and then sepsis, AKI, delirium, and many more. So we go through quite a few key ones here. So post-operative complications can be general or they can be specific to a particular operation, and they can be classified according to the time of onset, whether it's immediate, early, or late. Okay, so the first one will come to atelectasis. So what is atelectasis? So it's actually like a collapse of the areas of the lung, and this can actually result in pulmonary complications such as hypoxia. So if you see this image here, this image shows the lung with the carina, the right lung with three lobes, left lungs with two lobes separated by the oblique fissure, and here is the alveoli. So you can see in the picture downwards, the left lung is actually like reduced in size because of collapse. Yeah, so this is actually atelectasis. So, sorry. So if a chest X-ray is done, you could actually see here, like there's some consolidation, and so clinical examination may show reduced basal air entry with reduced lung volumes on chest X-ray. So what's the management for atelectasis? So we can provide humidified oxygen, also symptomatic treatment, especially anesthesia if someone is having pain, trying to promote them to cough, and also the roles of chest physio to try to get them to improve their lung function, and also to provide CPAP, which is continuous positive airway pressure. Okay, after that we come to post-operative hemorrhage, which is quite an important one as well. When I was in my HPB placement, I did come across a case where a woman who just I think a few days after she had her whipples, yeah, suddenly from like her drains, there was blood, and then everyone was quite shocked, and then there had to be like emergency laparotomy. Yeah, so post-operative hemorrhage can be quite distressing for both patients and also healthcare professionals. So hemorrhage can be split into three, which is primary, reactionary, and secondary. So primary means bleeding occurs within intraoperative period, meaning during the surgery. Reactionary means hemorrhage occurs within 24 hours of operation. So this could be due to a ligature that slips or missed vessel. And this can often be missed intraoperatively due to intraoperative hypotension and vasoconstriction. Whereas a secondary hemorrhage occurs 7 to 10 days post-operatively. So there's quite a period of time after surgery. And this is often due to erosion of a vessel from a spreading infection, such as when a heavily contaminated wound is closed primarily. So here's a table showing patient of hemorrhagic shock with four classes by the American College of Surgeons Advanced Trauma Life Support. So here it shows that the percentage of blood loss as well the heart rate, blood pressure, so the key vital signs into classification of hemorrhagic shock. Okay, so what are some risk factors or what makes someone more prone to bleed after surgery? So for example, if someone who is on some particular drugs such as heparin, warfarin, NSAIDs, antiplatelets, so you notice that it's more like the anticoagulant, antiplatelet drug groups. Or if someone has congenital bleeding disorder such as von Willebrand disease, hemophilia A or B, and there's also if someone has acquired bleeding disorder such as disseminated intravascular coagulation, sepsis. Yeah. Okay, now we come to delirium. So what is delirium? Okay, so delirium is actually an acute confusional state which can occur post-operatively in any patient, and it can be more especially prominently seen in the elderly care or like geriatrics wards. And there are many reasons for delirium. There are some acronyms used for delirium like pinch me, pain, infection, malnutrition, nutrition, uh, medications. So these are a lot of factors can lead to delirium, where someone is just confused at that moment of time and place. So there can be hyperactive delirium, or a mix in between. For someone who is hyperactive delirium, someone can be very agitated. Friends and families will say that they are like unusual. Their behavior is more unusual. They're getting very agitated. Whereas hypoactive delirium, you may just see the patient sitting quietly in his or her chair, or he or her may just be lying on the bed for the whole day, or mix could be an in between both. So there are quite a few risk factors for delirium as shown here, like pain, sleep disruption. Even for patients who have like extended stay in the hospital, can also lead to delirium, as well as like delirium secondary to infections, medications, age, and many more. And now we come to reduced bowel function, which is a key thing that happens after surgery, particularly for like GI surgeries. So we call it ileus, where there's reduced like peristalsis. So this reduced bowel function can actually lead to abdominal distension. Someone may be more prone to nausea and vomiting with increased intra-abdominal pressure and reduced absorption of oral drugs. So constipation is a key thing that we try to take note of, especially in patients after surgery, because as there are many painkillers, opioids can tend to cause constipation as well. So we monitor their their stool chart, the Bristol stool chart, and management can include ensuring that they are adequately hydrated if they do not, especially if they are not like under heart failure, so then they should drink more. Also, the appropriate nutrition and laxatives, and post-operative ileus can be caused by intraoperative bowel manipulation, pain, immobility, hypokalemia, and yeah, all parts. So usually ileus will resolve around 24 to 26 hours, and management includes insertion of a nasogastric tube analgesia, and/or reduce oral intake. However, if it's longer than that, then you probably could suspect a small bowel or large bowel obstruction, which could be something more sinister. So now we come to the third poll question, which is, what do you guys think is the most common cause of post-operative fever in the first 48 hours surgery?
So 46% have said surgical site infection.
Okay. Okay, so it's actually surprisingly, it's actually atelectasis, which is actually the partial collapse of the lung, um, in the first 48 hours after surgery. So actually, the key word here or is the duration of time after surgery. So, atelectasis, uh, it occurs due to shallow breathing and reduced lung expansion after surgery, especially for those who undergo abdominal or thoracic surgery. So, person can present with fever, which is usually low grade, and this comes about with some respiratory symptoms such as cough or dyspnea. So, yeah. Whereas surgical site infection is also a common cause of fever, however, is usually beyond the initial 48 hours. And the other options here include DVT, which could also lead to fever, but is less likely to be the cause in the first 48 hours. And UTIs can also typically lead to fever. However, they are more common in patients who have catheter in situ for a long time. Okay, yeah. Now we come to next question, which is actually a question as well. Which of the following is a key risk factor for the development of postoperative delirium? So we talk about like delirium. Someone is in an acute confusional state.
93% have said advanced age.
Okay. Yep, brilliant. You guys are right. So advanced age is actually one of the strongest risk factor for the development of post-operative delirium. So the elderly are actually more susceptible to um, cognitive decline, especially if they are not really active usually, and usually they would have multiple comorbidities such as metabolic syndromes like high blood pressure, diabetes, hypercholesterolemia, and due to those few conditions, they're usually on many medications like with the polypharmacy, and with mild cognitive impairment, that could also lead to changes in brain function. So delirium is actually a really common post-operative complication, particularly after major surgery or when there's other stresses such as infections or metabolic disturbances. So high BMI, regional usage of regional anesthesia, long duration of surgery could also influence post-operative recovery, but they are not as strongly linked to delirium as advanced age. Yeah. Okay, so now we've come to almost the final part of our presentation, which is the post-surgical patient review. So your patient has gone through a tough, long day of surgery, and like after covering the preparation before surgery, during surgery, and now it's after surgery. So surgery is done. So what do we do? So first, again, on the post-take ward round, coming in the morning, see patient again, uh, making their notes, patient demographics, their full name, age, listing down what operation they did and post-operation, like what's what day they are post-operation. Is it day one, day one post-op, day two post-op? These are key informations which should be listed down during one round. The type of operation they underwent, is it a lab chole with post procedure, and what's the reason behind it, and like what's the plan management for it. Yeah, so we'll go through some of that as well. So in terms of investigations that we'll do is like uh, FVCs, where we check their inflammatory markers like white blood cell count, CRP is quite important. So this may rise for the first 2 days post-operatively, but it should fall after that. Yeah, because the half-life of CRP is about like 19 hours. And then also like things like hemoglobin, electrolytes, especially try to electrolytes if you know they're a bit haywire, then it could cause arrhythmias and more other complications. And of course, other new investigation results if anything does pops up. Okay, so here covers like a wide scope of what we would do. For example, when we're clerking a patient, we ask them, are they feeling any symptoms, any issues? You know, are they eating and drinking well? If they could, have they been able to sleep well? Is the pain controlled? You know, as pain is definitely a key thing after surgery, and you know we always try to keep patient as comfortable as possible. Are they mobilizing well? We don't want them to stay in bed for too long, you know. And if they are, is PT prophylaxis in place? And the nursing charts, their observations, fluid balance, you know. um, for example, especially if after they underwent abdominal surgery, are there any aspirates from the NG tube, anything like that? Stool charts, you know, if someone, you know, is like last bowel movement about 7 days ago, that could be a cause for concerns, you know, and you want to explore more about that. The food charts, are they eating well? What type of food are they eating? You know, should they be on a low-fat diet? You know, depending on the surgery that they have underwent. And of course, examination as well. For example, tubes in situ. Do they have a chest drain in place? Do they have wound catheters? You know, and drain quantity and output. For example, someone who is underwent a Whipple's, you know, having drains, you know, trying to check the drain MLS. You know, what's the color of the drain? Is it cow? You know, or anything like that? Any wounds? You know, inspection of the surgical site, you know, whether it's any infection, rashes, you know, and of course, if deemed necessary, focus systems examination. So these are actually all part of the patient assessment uh, done after surgery. So after surgery, it doesn't stop there. You know, there's still much to be done to ensure that, you know, patient is, you know, recovering well and making the necessary steps to get back to the normal state which they were in. And of course, based on after all this assessment, you make the necessary plan based on impression and also to for medications review. So yeah, sorry guys, I think just in time. Yeah, so here are my references. So most of them are from NICE guidelines, and yeah, so yeah, I've reached the end of this presentation. Does anyone has any questions or you like to discuss or share about any topics which we cover in today? Would be more than happy to do so.
Thank you, Joe. That was really, really good. And I hope all of you enjoyed it as much as I did. Before I carry on, I want to invite Kona, who's one of the founders and directors of SUPTA, to talk to you about our learning portal.
Hey, Joe. Wonderful session. Thank you so much, mate. Just before we get on to the Q&A bit, I just want to show you guys the learning portal that we've set up for SUPTA this year. I'll share my screen. So for those of you that were here yesterday, you'll be familiar with this, but on our website, supta.uk, we've built this new learning portal to go along with our teaching sessions this year. So as you log into the website, you'll see this join now for the learning portal. You'll click this and you'll be prompted to create an account on the website. You have to create 2 accounts to access it, which is a bit an annoying quirk of the system, but there you go. And when you log into the learning portal, you'll be presented with this landing page. You can click the learning portal link and it has recaps of all of the sessions which we're delivering this year, including the one which Joe's just delivered to you. So you can click the session. We'll have a recording of the session at the top, and then some bullet point summaries summarizing the content to go along with it. And at the bottom of each page, we've got a whole load of multiple choice questions that you guys can answer to recap your knowledge and consolidate it for the sessions. Along with that, we've got a dedicated multiple choice question bank with questions that we'll be adding to after every session. So at the moment, there's only a small number, but before long, it will be a very large question bank and a good source of revision for you guys. I'll leave it there. Thank you so much, Joe.
Thank you.
Thank you, Connor, and I hope that convinces all of you to go get a SUPTA membership. Just a couple final bits now. The feedback form is available in the chat, so don't forget to fill it out to receive your certificates and discount codes to teach home surgery and pass the MRCS. Also be sure to complete the Google form for a chance to win a free access to the Geeky Medics surgical flashcards and their OSCE stations. The link for this is available on the chat, and the unique code is also available. Our next session will be on the 10th, which is next Monday at 6:30, and this is going to cover cardiothoracic surgery. So we'd love to have you guys again with us. Make sure to follow us on the social media platforms. The links for all of this is available in our chat. You will be able to receive updates on our upcoming sessions via all these platforms. We've also posted additional SPAs on our learning platform that Connors just showed you, so definitely check that out. We hope you found today's session helpful and engaging, and we'll see you guys next week. Thank you, everyone.
Yes.